Welcome to the Deep Dive, where we take your source material and unpack it to find the most valuable insights.
Today, we're diving into the world of pediatric care, drawing from key concepts in a textbook about nursing children.
Our mission in this deep dive is to give you a shortcut to understanding the core philosophies, how kids grow impacts everything, crucial safety priorities, and some unique health considerations when caring for the youngest patients, from the first moments of life through the teen years.
Okay, let's unpack this.
Get ready to explore what goes into ensuring a child's well-being in a healthcare setting and why understanding these aspects is vital for anyone interested in healthcare for children.
Let's start by looking at the big ideas that shape pediatric nursing.
Absolutely. When we think about caring for kids in a medical setting, it's not just about treating an illness. It's about creating an environment where they and their families can thrive.
Right. And one model the source highlights is the pediatric medical home.
Okay.
Think of this less as a physical place and more like a comprehensive network,
Okay. Like a system.
Exactly. It's a proactive program, often targeting children with disparities, that focuses on getting them in for timely well-child visits, coordinating their care across different providers, supporting families during transitions, and connecting them with resources not just medical, but things like social services, too. It's about wrapping support around the child and family.
That makes a lot of sense looking at the whole picture.
Yeah.
And a core principle you hear everywhere in pediatrics is family-centered care. Our source really emphasizes this as a fundamental partnership.
It truly is a partnership between the patient, the family, and the healthcare team, especially the nurse. The material stresses that having parents actively involved isn't just nice, it's essential.
Right.
The core ideas are simple but profound. Treating everyone with dignity and respect, sharing information openly and honestly, ensuring the family participates in decision-making.
Genuinely participates.
Yes, and genuinely collaborating on the care plan.
And the source gives some really practical examples of how this plays out, doesn't it?
It does. Like providing access to a fridge for parents to store food from home, offering free meals for nursing mothers, or even adjusting nursing tasks to fit the child's typical routine from home as much as possible.
Little things, but they mean a lot. It's about making the healthcare setting adapt to their lives.
Exactly. It's about recognizing that the family is the constant in the child's life.
Okay. And building on that collaborative idea is relationship-based care. The source touches on that too.
Briefly, yeah. This focuses on building trust through open communication, actively engaging both the child and their family, and really tailoring care to that specific individual's needs and situation.
So it's not just a medical transaction, but a human connection. The source also highlights the vital role of child life specialists. Who are these experts and what do they actually do?
These are professionals with deep expertise in child development who work in all sorts of pediatric environments, the ER, the ICU, inpatient units, clinics. Their main job is to help kids cope.
Cope with the stress and anxiety of it all.
Right, the stress of being in healthcare. They use therapeutic play, maybe letting a child give a shot to a doll before they get one to teach them about procedures and help them process what's happening.
That's smart.
Yeah, it helps normalize the hospital experience. They can even help coordinate things like donations and volunteers.
That sounds incredibly valuable for reducing potential trauma. Shifting slightly, our source also digs into culturally competent nursing care. What's the ethical obligation outlined here?
The key is assessing and actively working to accommodate a patient's and family's cultural and spiritual beliefs, values, and traditions, because these significantly impact how they experience and follow healthcare advice.
Right, affects everything.
It does. The source is clear. Nurses have an ethical obligation to make a sincere effort to understand and accommodate these beliefs, provided it's safe, feasible, and within professional standards.
And this is where understanding the why behind different practices becomes crucial for you, the listener. Yeah. What are some examples of these accommodations?
Oh, they cover a wide range. Dietary needs are common. Using qualified interpreters is a must. The source specifically says children and family members should never be used as interpreters.
That's a really important point. Why is that?
Well, there are issues of accuracy, confidentiality, and emotional burden, especially on a child. You need a professional.
Got it. What else?
Scheduling care around prayer times or religious observations, maybe ensuring access to electricity during Sabbath for Orthodox Jews. It can even involve respecting decisions about treatments based on religious beliefs.
Like the Jehovah's Witness example.
Exactly. Understanding that adults might refuse blood for themselves but consent for their children. It also extends to gender and privacy needs and being aware of complementary and alternative therapies a family might be using.
It highlights how many layers there are to providing truly patient-centered care. And all of this matters deeply because, as the source points out, culture significantly impacts how care is received and followed.
Absolutely. If we don't acknowledge and respect these aspects, we risk poor adherence to care plans and causing significant distress.
That makes perfect sense. Let's shift gears and look at some current trends and outside factors that impact pediatric health.
Okay. Our source points to a few significant ones. One is the rise in childhood obesity.
Yeah, that's everywhere in the news.
Noting it has doubled in prevalence since the 1990s.
Doubling is a striking increase. What are the long-term consequences the source links to this trend?
The material lists significant lifelong consequences, including increased risk of diabetes, stroke, heart disease, arthritis, certain cancers, hypertension, and asthma, as well as psychosocial issues. It's a major public health concern.
Definitely. And the source gives specific guidance on how healthcare providers should approach this sensitive topic, right?
Yeah.
It's not easy.
No, it's not. And the guidance is absolutely crucial. Discussions must be non-judgmental. The source explicitly warns against body shaming, parent shaming, or causing embarrassment.
The focus needs to be on health and support, not blame.
Exactly. That non-judgmental approach is essential for building trust.
Okay. Another trend mentioned is the increasing need for culturally sensitive and non-discriminatory care for children and adolescents who identify as LGBTQ plus CAM.
Yes. The source emphasizes providing support and comprehensive care. Nurses are encouraged to assess for specific risk factors prevalent in this population, such as depression, suicidal thoughts, substance abuse, and experiences with bullying or discrimination.
And using appropriate language.
Vitally important. Using gender-affirming language, especially with transgender youth.
Here's where understanding the why gets really interesting, especially regarding privacy for adolescents. This is a big one for listeners to grasp.
This is a critical point the source makes, yes. If a patient discloses information about their sexual orientation or gender identity, healthcare providers often do not have a legal obligation to share that specific information with parents or caregivers. It depends on the state and the specific situation, but that's the general principle for certain types of information.
Wow, that balances parental involvement with the adolescent's right to privacy, especially as they mature. Why is this level of awareness and sensitivity so necessary?
Because these factors profoundly impact a child's health and safety. Ignoring issues like bullying, discrimination, or mental health struggles can have severe consequences. Healthcare providers need to be aware and proactive in their assessments and support.
Shifting back to environment, the source also discusses how a child's home environment significantly influences their care. How so?
It has a substantial impact on, well, pretty much everything. Care delivery, diet, medication access, privacy. The source says nurses should assess factors like family structure.
Like how many kids are in the home?
Right. Knowing if there are many siblings can indicate potential challenges for a parent managing complex care for one child. Socioeconomic status affects where they live, access to health care, financial resources for meds or specific foods.
And safety in the home environment.
That's another key assessment area. For example, if a child needs crutches, does the nurse need to talk about stairs? If they have a pool, stress drowning prevention is crucial.
Understanding the home context is clearly vital for effective care planning. All of these points circle back to the importance of communication, which the source calls therapeutic communication.
That's defined as communication that is mutually positive and acceptable to everyone involved, the child, the family, the healthcare team. It's about recognizing each individual's uniqueness.
And that builds trust, right?
Exactly. This approach is fundamental because it's the basis for building trust and those effective partnerships we've discussed.
Okay, let's really dig into something fundamental to pediatric care. Understanding how children grow and change. Because caring for a child isn't just caring for a smaller adult. Their developmental stage is key.
Absolutely. The source highlights major developmental theories that help us frame this. Jean Piaget's work on cognitive development is foundational. It's all about how kids think and learn at different ages.
Right. Piaget described this sequential process of how children's thinking becomes more complex. And his stages are crucial for you listening because they tell us how to communicate effectively with a child.
Exactly. There's the sensorimotor stage, birth to 2 years. Infants learn through senses and actions, figuring out object permanence, that things exist even when hidden.
Like peekaboo.
Precisely. Then pre-operational, 2 to 7 years. Thinking is more magical, symbolic, language explodes, but they're very focused on the present. You need simple, concrete explanations.
So no abstract concepts yet?
Not really. Next is concrete operations, 7 to 11 years. They start thinking logically, but about tangible things, things they can see or touch. This is the age where the source stresses letting them ask questions about their care is key for teaching.
Let them ask why.
Yes. Finally, formal operational, 11 through adulthood. Now they can think abstractly, hypothetically, use deductive reasoning. You can have much more complex discussions.
So the way you explain a procedure to a 4-year-old is vastly different from how you'd explain it to a 14-year-old. And Piet tells us why.
The source also mentions Freud and Kohlberg briefly.
Yeah, briefly. Freud focused on psychosexual development. While influential historically, it's, pretty controversial today and not as directly applied in daily care. Kohlberg looked at social moral development, how kids learn right from wrong, moving from just following rules to developing their own values. They provide context.
But Erikson's psychosocial development theory seems particularly relevant for healthcare settings. He focused on resolving social or emotional challenges at each stage, right?
That's right. The source covers key stages relevant to how a child might behave, especially in the hospital. Trust versus mistrust, that's birth to 1 year. Are their needs met consistently? If yes, trust develops. If not, mistrust.
Okay.
Autonomy versus shame and doubt, 1 to 3 years. Toddlers want independence. They say no a lot. If they're constantly criticized or restricted, they can develop shame and doubt their abilities.
The terrible twos are about autonomy then. Largely, yes. Then, initiative versus guilt, 3 to 6 years. Preschoolers learn through play, trying out roles. If they're shamed for their choices or actions, they can develop guilt and hesitate to take initiative.
Interesting.
Industry versus inferiority, 6 to 12 years. School-aged kids focus on rules, competence, taking pride in accomplishments. Learning they can't be good at everything is part of finding balance, avoiding feelings of inferiority.
And for teens?
Identity versus role confusion, 12 into adulthood. Teens are figuring out, who am I? They're very preoccupied with how others see them. Difficulty navigating this can lead to role confusion.
So how does this framework actually help nurses understand a child's behavior, especially in a stressful place like a hospital?
It helps explain the behavior. It provides context for you, the listener, too. A toddler refusing medication isn't just being difficult. They might be asserting their need for autonomy that Erikson talked about.
Right, it reframes it.
Exactly. A school-aged child who wants to help with their dressing change might be demonstrating industry. Understanding these normal developmental drives allows providers to respond supportively rather than just seeing defiance or non-compliance.
That makes a huge difference. The source also mentions developmental milestones, those expected achievements like sitting or walking by certain ages.
Yes, they serve as benchmarks. The source notes that missing milestones can indicate a need for assessment, possibly involving therapists, PT, OT, speech, or even medical intervention.
Any examples?
Yeah, it gives specific language examples, like if an infant isn't cooing or babbling, maybe there's a hearing issue. Or if a toddler or preschooler isn't stringing words together, or strangers can't understand a 5-year-old, that could signal a speech delay needing evaluation.
Okay, let's talk about what care looks like specifically for different age groups, because a newborn's needs are so different from a teenager's. Starting with newborns, those crucial first hours and days.
It's a period of rapid adjustment, yeah. Immediate post-birth care prioritizes clearing the airway importantly, mouth before nose, to avoid inhaling secretions if they gasp.
Ah, good point.
Then drawing and stimulating them helps with warmth, thermoregulation, and assessing their transition with APGAR scores at 1 and 5 minutes, looking at heart rate, breathing, muscle tone, reflex irritability, color. You want a score of 7 to 10 ideally.
And security is immediate too.
Yes, security banding right away to decrease abduction risk.
And key medications are given right away. What are those again?
Vitamin K, that's for blood clotting, since their gut doesn't make it yet. Erythromycin eye ointment to prevent certain eye infections they could pick up during birth. And the first dose of the hepatitis B vaccine.
Got it. The source details many normal newborn characteristics that can sometimes worry new parents but are usually fine. Can you give us a couple of examples, maybe some skin things?
Sure. Acrocyanosis, that bluish tint to the hands and feet, totally normal for the first 24-48 hours as their circulation adjusts. Melia, tiny white bumps, usually on the nose or face. Just blocked oil glands, leave them alone, they go away.
Good to know. What about Mongolian spots?
Right, those are common, typically blue-gray patches, often on the lower back or bottom, especially in infants with darker skin tones. The key thing is to document them clearly so they aren't mistaken for bruises later on.
Documentation is key there. It's about knowing what's expected and what's a red flag. And what about newborn reflexes? These are fascinating.
They are. Reflexes are involuntary movements that show the nervous system is working. The source lists many, like the Moro reflex, the startle response where they throw their arms out, or rooting, where they turn their head towards a touch on the cheek, looking for the nipple.
What about the Babinski? That one's interesting.
Yes, the Bumsky reflex. When you stroke the sole of an infant's foot, their toes should fan out and up. If they curl down like an adult's, it could signal a neurological issue. Most of these reflexes disappear in the first few months as the brain matures.
The source also covers anticipatory guidance for newborns, basically preparing parents for what's coming. What does that involve?
It's really psychological preparation to ease anxiety and build confidence. Topics include explaining those normal newborn behaviors and appearances we just talked about, discussing upcoming developmental milestones, covering essential safety like childproofing and car seats.
Super important.
Talking about nutrition, oral health, and importantly, stressing the significance of infant and child CPR training. Just knowing what to do can make parents feel so much more secure.
Absolutely. And a major focus of safety guidance for newborns is SIDS prevention.
Yes, sudden infant death syndrome. It's still the leading cause of death for infants between 1 month and 1 year, peaking between 2 and 4 months. The source emphasizes the back to sleep program.
Which means?
Always place infants on their backs for sleep, for every sleep. Keep the crib totally empty, no blankets, pillows, bumpers, stuffed animals, just a fitted sheet on a firm mattress.
Nothing else in there.
Nothing. Babies should sleep alone in their crib or bassinet, not co-sleeping in an adult bed. Breastfeeding and pacifier use during sleep are actually protective. And maintaining a smoke-free environment and using a fan in the room to circulate air and prevent overheating are also key recommendations.
Okay, crucial advice there. Moving on to toddlers, ages 1 to 3. What's unique about caring for this age group?
Well, physically, you're usually getting their height standing up now. You might notice a little lordosis, that inward curve in their lower back, which is common. Head circumference is still measured until age 2.
And toys.
The source mentions age-appropriate toys like stuffed animals, blocks, books, Play-Doh, maybe a tricycle. It highlights that these aren't just for fun. They support crucial development motor skills, problem-solving, language.
Right, play is learning for them. How about school-aged children, 6 to 12?
Their vital signs start getting closer to adult ranges. Temperature is important. The source notes watching fevers over 100.4 degrees ARI and treating over 100.4 degrees ARV and treating over 101.4 degrees AR due to the potential risk of febrile seizures in susceptible kids.
And pain assessment.
You can use scales like the FACES scale with the different expressions or a simple 0-10 number scale. But for this age, the source really stresses involving parents. They know their child's subtle signs of pain better than anyone. Don't just rely on facial expressions.
And the source points out something important about giving this age group choices, making them feel valued.
Yes, they're moving towards more independence, right? Erickson's industry stage. Offering simple choices like which arm for the blood pressure cuff, or would you prefer the thermometer under your arm or in your mouth? Respects their growing autonomy. It makes them feel more in control and less like a little kid being told what to do.
Makes a big difference in cooperation, I bet. Finally, adolescence, 12 to adulthood, a period of huge change. What are the key considerations here?
Privacy becomes paramount with teens. The source emphasizes explaining every step of the physical assessment and why you're doing it. You need to build trust.
And specific things to look for.
Beyond the standard checks, you might look for subtle signs of risk. Skin assessment might reveal self-harm marks like scratches or erasure burns. Examining the mouth might show tooth erosion, which could indicate induced vomiting related to an eating disorder. And remember, their frontal lobe, responsible for judgment and impulse control, is still developing into their early 20s.
That's important context. How about pain?
The numeric scale usually works well, but the source notes something interesting. Vague physical symptoms like headaches or stomach aches without clear medical cause in a teen could signal underlying issues like depression, anxiety, abuse, or just overwhelming stress, worth keeping in mind.
And that point about privacy and confidentiality is especially critical here, right?
Absolutely. Teens strongly desire privacy. The source stresses the importance of assessing them without a caregiver present whenever possible to maximize confidentiality.
But there are limits to that confidentiality.
Yes. While laws vary by state, generally, information shared by an adolescent about sensitive topics like reproductive health, Sexuality, gender identity, substance use, or mental health is kept confidential. However, there are critical exceptions.
Okay, what are those exceptions where confidentiality cannot be maintained? Listeners should know this.
Right. Confidentiality must be breached if the teen is believed to be in imminent danger, meaning a serious threat to harm themselves or someone else. Also, if there is suspected or confirmed child abuse or neglect, that must be reported. And finally, if they're diagnosed with certain communicable diseases that require reporting to public health authorities.
Is a really delicate balance healthcare providers have to navigate.
Extremely delicate, building trust while adhering to legal and ethical safety obligations.
The source also highlights bullying as a significant issue for this age group.
Yes, it defines it clearly. It's peer-to-peer, unwanted, aggressive behavior involving a real or perceived power imbalance, and it's repeated over time.
And it's common.
Sadly, yes. The source notes it's a common cause of school avoidance and significant emotional distress. Assessment should look for those characteristics: aggression, repetition, power imbalance. It can be physical, verbal, or cyberbullying.
What are the risks for kids who experience bullying?
They're serious. Increased risk of depression, anxiety, sleep problems, lower academic achievement, sometimes turning to risky behaviors themselves, and long-term mental health problems.
And the source makes a point about advice often given.
Right. It specifically says that simply telling kids to just ignore bullies does not work. It requires more active intervention and support strategies.
Good point. Okay, quickly, the source also includes typical sleep needs for different ages.
Yes, and they change dramatically. Newborns might sleep up to 17 hours total, but in short 3-4-hour bursts, often feeding to feeding. They don't usually sleep through the night until maybe 3 months or older.
And older kids.
By 1 year, maybe 15 hours total, with longer stretches at night and maybe a couple of naps. School-aged kids need less, maybe 9-11 hours. Teens still need a lot, maybe 8-10 hours, but their natural sleep cycle shifts later, which often clashes with school start times. Understanding these norms helps guide parents.
And circumcision is touched upon briefly. What's the key takeaway?
It's the surgical removal of the foreskin. The source lists reasons parents choose it: religious, cultural, perceived, hygiene benefits, social norms, but it clearly states there is no absolute medical necessity for routine circumcision.
And the nurse's role.
To be completely non-judgmental and support the family's decision. Key education for parents post-procedure is knowing warning signs: persistent bleeding, more than a quarter-size spot, increasing redness or swelling, fever, pus, or discharge, or the baby not urinating normally within about 12 hours.
And for uncircumcised boys?
Crucial safety point: never forcibly retract the foreskin. Gentle cleaning of the exterior is all that's needed.
Got it. Safety is clearly paramount in pediatric care, both in and out of the hospital. Let's look at preventing harm within the hospital first.
Absolutely critical. Using 2 patient identifiers, usually name and date of birth, is non-negotiable before giving medications, doing procedures, collecting specimens, any intervention.
Even if the nurse knows the child?
Even if the nurse knows the child extremely well, it's a fundamental safety check.
Oh.
And it's harder with kids, right? Bands get pulled off, infants can't tell you their birthday, so you often involve the parent in identification too.
Makes sense. What about falls?
Kids are definitely prone to falls in unfamiliar environments. The source mentions programs like the Humpty Dumpty Falls Prevention Program. A key requirement highlighted is that cribs for children under 4 years old must have bubble tops or high side rails. And the most critical rule: side rails on cribs and beds must always be up and latched whenever a caregiver isn't right there at the bedside.
You lower it, you are the side rail.
Exactly that mindset. Be aware of cords too, IV tubing, monitor wires, potential hazards.
Okay, that leads to safety outside the hospital. The source mentions accidents and injuries are the leading cause of death for children under 19.
Sadly, yes. A stark reminder of why prevention is so important, and the source highlights the nurse's role here: advocacy, protection, reporting, and caring for the patient if injury occurs.
And reporting is mandatory.
Yes. It's crucial for our listeners to understand. Nurses are mandated reporters in all 50 states. Any reasonable suspicion of child abuse or neglect must be reported to Child Protective Services or law enforcement immediately, always within 24 hours.
But nurses don't investigate.
Correct. The source is clear. The nurse's role is to report and care for the child, not to investigate the allegations. That's the job of CPS and law enforcement.
Okay. What are some key safety education points nurses share with parents?
Lots of things. Pool safety is huge. Never leave children unattended near water, even for a second, even if they know how to swim. Use barriers like fences and gates. Ensure kids wear life jackets when appropriate. Don't leave toys floating in the pool, as they can attract a child back to the water.
What else?
Trampolines are explicitly called out by the source as incredibly dangerous due to high risk of fractures and head injuries. Crosswalk safety, teaching kids how to look both ways, wait for traffic. Bicycle safety, always wear a properly fitted helmet. No riding in the street until they have the skills and judgment.
And car seats, always a big one.
Absolutely critical. Keep kids rear-facing as long as possible until they reach the maximum height or weight limit for their seat, often around age 2 or even older now. Then transition to a forward-facing seat with a 5-point harness, again, until they max out those limits. Never leave a child unattended in a car, not even for a minute. And infants shouldn't sleep in car seats outside of the car. The angle isn't safe for prolonged sleep if the seat isn't installed in its base.
So much important information there. Finally, the source details signs of child abuse and neglect, something healthcare providers must be vigilant for. It's tough, but necessary.
It is. Abuse is defined as intentional actions causing harm or injury. The source lists common forms. Shaking baby syndrome, violent shaking, causing severe head trauma, usually affects infants 3 to 8 months. The number one identifier mentioned is detached retinas. It causes devastating brain damage or death.
What about other types?
Sexual abuse signs might include stained or bloody diaperless underwear, genital bruising or bleeding, pain, excessive crying, changes in behavior, or even failure to thrive. Physical abuse can show up as unexplained or repeated injuries, welts, bruises, especially in patterns or shapes like from a belt buckle or cigarette, burns, broken bones. Look for explanations inconsistent with the injury or injuries unlikely for the child's age or developmental ability. Fearful or detached behavior can also be a sign.
And neglect.
Neglect is the persistent failure to meet a child's basic needs: physical, emotional, medical, educational. It might look like a child who is consistently dirty, dressed inappropriately for the weather, malnourished, denied necessary medical or dental care, or left unsupervised.
These are difficult realities, but essential knowledge for anyone involved in pediatric care or, frankly, anyone in the community. Let's briefly touch on a few common pediatric health conditions mentioned in the source, shifting back to more medical topics.
Okay. Phenylketonuria, or PKU, is mentioned as the most common inherited error in metabolism. Babies lack an enzyme needed to break down an amino acid called phenylalanine, which is found in protein.
And it's screened for.
Yes, all newborns are screened, usually twice, once after they've had milk for at least 24 hours, and again at about 7-10 days old. If untreated, PKU causes irreversible brain damage, intellectual disability, seizures, behavior problems, skin rashes, and a musty body odor.
How to treat it?
Treatment is a lifelong, extremely strict, low-protein diet. That means NO, meat, dairy, eggs, nuts, dry beans. They need special medical formulas. And specifically, the source notes infants with PKU cannot be breastfed because breast milk contains phenylalanine.
Wow, lifelong dietary management. What about galactosemia?
Another inherited enzyme deficiency, this one preventing the breakdown of galactose, a sugar in milk, into glucose. Also screened for in newborns in all 50 states. Untreated, it can cause intellectual disability, brain damage, cataracts, jaundice, liver enlargement, and kidney disease.
And the dietary fix.
Requires a completely lactose-free diet, which usually means using a soy-based infant formula.
Okay. Hyperbilirubinemia, or jaundice, we touched on this with newborns. Can you recap the key points?
Sure. Bilirubin is a byproduct of red blood cell breakdown. Hyperbilirubinemia is when there's too much bilirubin in the blood, causing that yellowing of the skin and eyes known as jaundice. It's very common in newborns, mainly due to their immature liver not being able to process bilirubin efficiently yet.
Risk factors.
Prematurity, liver immaturity, and sometimes breastfeeding can be associated with higher or more prolonged jaundice.
And what do nurses do?
Assess the skin frequently. Check bilirubin levels with a heel stick blood test if needed. If phototherapy, the UV light treatment, is required, the baby usually wears only a diaper and special eye protection goggles. You have to make sure the eyes are covered properly. And turn the lights off before drawing blood to recheck levels, as the light can affect the sample.
Got it. And lastly, iron deficiency anemia.
This is the most common type of anemia in children, meaning not enough healthy red blood cells to carry oxygen efficiently. Often caused by dietary deficiency, especially common in infants and toddlers who are given cow's milk too early or drink too much of it, crowding out iron-rich foods.
What are the signs?
Can include irritability, poor appetite, anorexia, rapid heart rate, tachycardia, sometimes a heart murmur, brittle or concave fingernails, poor muscle tone, being prone to infections, pale or porcelain-like skin, sometimes edema, slow growth, and even delayed learning.
How is it managed?
Treatment usually involves oral iron supplements. Liquid iron should be given with a straw or placed in the back of the mouth to avoid staining teeth. Education is key. Use iron-fortified formula for infants not breastfed. Avoid cow's milk entirely before 12 months. Whole milk is recommended from 12 months to 2 years, but limit intake so they eat iron-rich foods. Breastfed infants might need an iron supplement starting around 4 to 6 months if they aren't getting enough from complementary foods. And encourage iron-rich foods for older children, meats, beans, fortified cereals.
Okay, we've covered a huge amount of ground in this deep dive, from the foundational philosophies of caring for children and understanding their development to crucial safety measures and common health conditions across different ages.
What really stands out, I think, is how interconnected all of these pieces are. You really can't truly care for a child effectively without considering their age, their specific developmental stage, their family's culture and background, their home life. All of that is just as important as their vital signs or lab results.
Absolutely. It really highlights the complexity, but also the profound impact pediatric care providers have. They're acting as advocates, educators, and essential partners with families.
Definitely. This deep dive gives you, the listener, a solid framework for appreciating the many, many layers involved in ensuring the health and well-being of children.
So what does this deep dive mean for you listening?
Well, next time you encounter information about pediatric health, maybe it's a news story, a conversation with a friend who's a parent, or perhaps even a personal healthcare experience for your own child, you'll have a much deeper context. You'll understand more about the unique care and considerations involved.
Think about the specific details we explored, like those different newborn reflexes and what they signal, the practical challenges of just identifying patients who are tiny humans, or that really crucial legal and ethical point about adolescent confidentiality. These specifics illustrate just how different pediatric care is from adult care.
They really do. They aren't just facts. They show the unique nature of this field.
So, for you to mull on, consider this. How does our understanding of child development, drawing from people like Piaget on how kids think logically, or Erickson on their emotional journey through stages like autonomy versus shame, or identity versus role confusion, fundamentally change how we should approach medical care and communication with a child? How can simply remembering which developmental stage a child is in make a real difference in a potentially stressful healthcare interaction, helping you better understand their reactions, their fears, and their needs?